Fungal skin infections, diagnosis, treatment, and management. Fungal skin infections represent a diverse group of dermatological conditions affecting millions worldwide. Understanding their classification, clinical presentation, and treatment options is essential for effective patient management. Understanding fungal skin infections. Fungal skin infections, medically referred to as mycoses, constitute a significant portion of dermatological presentations in clinical practice. These infections occur when fungal organisms colonize and proliferate within the layers of skin, hair follicles, or nail structures. The prevalence of fungal skin infections has remained relatively consistent globally, though certain geographic regions and climate conditions favor increased incidence. The spectrum of fungal pathogens capable of infecting human skin is extensive, ranging from dermatophytes that have evolved specifically to parasitize keratinized tissues to opportunistic yeasts that exploit compromised immune function. Understanding the fundamental nature of these infections provides the foundation necessary for appropriate diagnosis and treatment selection. Classification of fungal skin infections. Fungal skin infections are traditionally categorized into three distinct groups based on the anatomical depth of tissue involvement and the severity of infection. This classification system helps clinicians determine appropriate diagnostic approaches and treatment intensity. Each category encompasses different causative organisms and presents with varying clinical characteristics. The classification framework also has prognostic implications, as deeper infections generally require more aggressive therapeutic interventions. Understanding where a particular infection falls within this classification helps guide management decisions and patient counseling regarding expected outcomes. Superficial fungal infections represent the most common dermatological mycoses encountered in clinical practice. These infections remain localized to the outermost layers of skin, the stratum corneum, and do not penetrate into deeper dermal structures. Superficial infections typically present with visible rashes characterized by erythema, scaling, and sometimes pruritus. The majority of superficial fungal infections are caused by dermatophytes, which are filamentous fungi possessing specialized enzymes that allow them to digest keratin. Common manifestations include tinea corporis affecting the trunk and extremities, tinea pedis occurring on the feet, tinea cruris involving the groin and intertriginous areas, and tinea barbae affecting the facial hair region. Additionally, yeasts such as Malassezia species cause superficial infections including pityriasis versicolor, characterized by hypopigmented or hyperpigmented macules typically appearing on the trunk. Clinical presentation and symptoms. The clinical manifestations of fungal skin infections vary considerably depending on the causative organism, infection depth, and individual host factors. Superficial infections typically present with well-demarcated erythematous patches or plaques featuring fine scaling on the surface. Many patients experience pruritus ranging from mild to severe, though some infections remain asymptomatic. The appearance may include characteristic patterns such as a central clearing with peripheral advancement, described as the expanding ringworm lesion. Scaling patterns can appear powdery or maceration may be present in areas of moisture and occlusion. Subcutaneous infections may initially appear as small nodules or papules that gradually enlarge and may become fluctuant or ulcerate. Systemic infections present with constitutional symptoms including fever, malaise, fatigue, and weight loss, potentially progressing to organ-specific symptoms depending on dissemination patterns. Diagnostic approaches. Accurate diagnosis of fungal skin infections relies on a combination of clinical assessment, microscopic examination, and culture techniques. The diagnostic approach should be tailored to the suspected infection type and anatomical location. Direct microscopic examination of skin scrapings, nail clippings, or hair samples following potassium hydroxide preparation allows visualization of fungal elements including hyphae and spore morphology. Culture on specialized fungal media such as Sabouraud dextrose agar enables identification of the causative organism and provides sensitivity information for antifungal medications. Newer molecular techniques including PCR-based identification offer rapid and accurate identification of fungal species. Wood's lamp examination, though less specific than previously thought, may demonstrate characteristic fluorescence in some conditions such as erythrasma or certain cases of pityriasis versicolor. Imaging studies including ultrasound or magnetic resonance imaging may be necessary for subcutaneous infections to define the extent of involvement. Antifungal treatment options. Treatment of fungal skin infections encompasses both topical and systemic antifungal medications selected based on infection severity, location, and causative organism. Topical antifungal agents represent first-line therapy for most superficial fungal infections and include azoles such as miconazole and clotrimazole, allylamine derivatives like terbinafine, and polyene antifungals such as nystatin. These topical agents should be applied to affected areas and typically an additional margin of surrounding normal skin to encompass subclinical fungal colonization. Treatment duration typically ranges from 2 to 4 weeks, though longer courses may be necessary for infections in macerated areas or involving nails. Systemic antifungal therapy becomes necessary for infections that fail topical management, involve the scalp or nails, or affect large body surface areas. Oral azoles including fluconazole and itraconazole work by disrupting fungal cell membrane synthesis, while terbinafine inhibits ergosterol synthesis through a different mechanism. Therapy duration for systemic treatment varies from weeks to months depending on the organism and infection site. Key points: topical agents effective for most superficial infections when applied consistently to affected and surrounding areas. Systemic antifungals necessary for scalp involvement, nail infections, or widespread disease. Azole and allylamine classes represent mainstay antifungal medications with different mechanisms of action. Treatment duration should extend slightly beyond clinical resolution to prevent relapse. Risk factors and predisposing conditions. Multiple factors increase an individual's susceptibility to developing fungal skin infections. Warm, moist environments such as those found in skin folds, between toes, and in the groin provide ideal conditions for fungal proliferation. Excessive moisture from sweating, poor hygiene, or prolonged water exposure increases infection risk. Immunocompromised states including HIV infection, diabetes mellitus, and prolonged corticosteroid use significantly increase both the incidence and severity of fungal infections. Tight-fitting clothing and occlusive footwear reduce air circulation and create favorable conditions for fungal growth. Previous fungal infections increase the likelihood of recurrence, particularly if predisposing factors persist. Occupational exposures such as those encountered by agricultural workers or healthcare providers increase exposure risk. Family contact with infected individuals facilitates transmission of contagious fungal species. Prevention and recurrence management. Prevention strategies for fungal skin infections focus on reducing fungal exposure and eliminating environmental conditions that favor fungal growth. Maintaining proper foot hygiene including thorough drying between toes and using antifungal powder in high-risk individuals helps prevent tinea pedis recurrence. Wearing breathable footwear and avoiding prolonged moisture exposure reduces fungal proliferation in foot and groin areas. Regular bathing and body drying, particularly in areas prone to moisture accumulation, prevents yeast infections in intertriginous zones. Avoiding direct contact with infected individuals and their belongings reduces transmission risk. Using personal items including towels, nail clippers, and combs rather than sharing such items minimizes transmission of contagious organisms. For individuals with recurrent infections, prophylactic topical antifungals applied several times weekly during high-risk periods may prevent recurrence. Treating household animals that may harbor dermatophytes reduces the risk of zoonotic transmission. Special considerations in management. Specific populations and circumstances require modified diagnostic and therapeutic approaches for fungal skin infections. Pregnant patients require careful selection of antifungal medications, as some systemic agents carry teratogenic potential while topical agents generally pose minimal risk. Pediatric patients may require dose adjustment of systemic antifungals based on weight and age. Patients with liver disease require modified dosing regimens for hepatically metabolized antifungals and monitoring of liver function. Nail infections require extended treatment periods spanning months rather than weeks due to the slow growth rate of nails and the difficulty in achieving adequate antifungal concentrations in nail tissue. Infections in elderly patients may progress more rapidly due to age-related immune dysfunction and require more aggressive management. Diabetic patients with foot infections require particularly meticulous care given the impaired healing and increased infection risk in diabetes. When to seek medical attention. While many superficial fungal infections can be initially managed with over-the-counter topical treatments, certain situations warrant professional medical evaluation. Infections failing to improve after 4 weeks of appropriate topical therapy require culture confirmation and potentially different antifungal agents. Infections involving the scalp or involving more than a few scattered lesions typically require oral antifungal therapy and professional diagnosis. Nail involvement warrants medical evaluation to confirm fungal etiology and determine appropriate treatment, as other conditions may mimic fungal nail infections. Immunocompromised individuals with any suspected fungal skin infection should seek professional evaluation given the increased risk of dissemination or complications. Recurrent infections despite treatment and prevention strategies require investigation into underlying predisposing factors. Large areas of body surface involvement or severe inflammatory responses should be evaluated professionally to exclude alternative diagnoses and guide treatment intensity. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.